Hi everybody, and welcome to our module on respiratory failure. Many different disease processes can lead to acute respiratory failure, which means failure of the lungs to oxygenate the blood and excrete carbon dioxide. So things like pneumonia, COPD, pulmonary embolism, heart failure, all of these things can lead to acute respiratory failure. But whatever the cause, there are some common clinical features to all patients who have acute respiratory failure. First of all, they all complain of shortness of breath or dyspnea. Accessory muscle use means using muscles other than just the diaphragm to breathe, so patients with acute respiratory failure can be using their neck muscles and their abdominal muscles to try and ventilate the lungs more vigorously. And then finally, people with acute respiratory failure often develop confusion and lethargy. This is a point that we'll come back to a couple of times in this video because it's very important. When the CO2 level gets high, patients can develop what's known as CO2 narcosis. This usually occurs when the CO2 level gets over about 60, normal is about 40. What happens is the brain undergoes changes and the patient can develop confusion and lethargy. And the important thing to note here is that the oxygen level may be normal. So if a patient with respiratory issues has normal oxygen level but they are confused, that should be very alarming to you because that may be indicating that their CO2 level has become dangerously high. Remember that the point of the lungs is not just to oxygenate the blood, it's also to excrete carbon dioxide. So patients with acute respiratory failure have two problems. They have inadequate oxygenation of blood and they have inadequate excretion of carbon dioxide. The inadequate oxygenation of blood is diagnosed by finding a low PaO2 on a blood gas or a low oxygen saturation on an oximeter reading. And remember that there are three underlying physiologic mechanisms by which hypoxemia can occur. Those three mechanisms are VQ mismatch, shunting, and diffusion impairment. Of these three, VQ mismatch is the most common, and most disorders we see clinically, like COPD and heart failure and pneumonia, have multiple of these mechanisms at play, all leading together to cause hypoxemia. Inadequate excretion of carbon dioxide is diagnosed by a blood gas showing an elevated PaCO2. And remember that patients who have hypercapnia and elevated PaCO2 are always hypoventilating by definition. There are other mechanisms by which the CO2 level can go up, including dead space, but so long as the patient is able to increase their respiratory rate, they will not develop hypercapnia, they will blow off the extra CO2. Therefore, any patient who has a high CO2 level is by definition hypoventilating. Shown on this slide are some of the commonly used oxygen delivery devices that you will see used around the hospital. All of these devices can increase the oxygenation level. They do not help to remove CO2 though, and it's very important that you remember that. The one you'll most commonly see used is nasal cannula oxygen. It's very simple. It just flows a few liters a minute into the nose. Beyond that, there are different types of masks that patients can wear that improve the oxygen delivery. These range from the face mask to the venti mask to the non-rebreather mask. And then finally, high-flow nasal cannula is a device that can deliver very high flow of oxygen through the nose. Beyond those oxygen delivery devices, the next level of ventilatory support is mechanical ventilation. This involves hooking the patient up to a machine called a ventilator, which will force air into their lungs. This is going to help to improve the oxygen level, just like oxygen delivery devices. However, it also is going to help to remove carbon dioxide. So this makes ventilation different from simple oxygen delivery devices. Those devices can only raise the O2 level. A ventilator can raise the O2 level and also help the patient to blow off CO2. There's two ways to attach a patient to a ventilator. The first way is called non-invasive ventilation. This involves hooking the patient up to a ventilator attached to a mask with a seal as shown in this picture. This can only be done in patients who are alert and oriented, but this is often done as a first step to try and support the patient and avoid having to place them on mechanical ventilation, which requires insertion of an endotracheal tube. When patients are placed on a mechanical ventilator, like as shown in this picture here, you have to insert a tube into their trachea and then attach them to the ventilator machine. Having a tube in your trachea is very uncomfortable, so most of these patients need to be sedated while they are being supported on the mechanical ventilator. So here's a table summarizing the amount of oxygen you can deliver to a patient using the various treatments for acute respiratory failure. When you use a technique like nasal cannula, the patient inhales some pure oxygen through their nose, but they also breathe through their mouth. As a result, the amount of oxygen delivered to their lungs is a mixture of that coming from the nasal cannula and that coming from room air. The FiO2, meaning the percentage of oxygen in room air, is about 21%. If you place a patient on nasal cannula oxygen, you can deliver 2 to 6 liters per minute of pure oxygen, and you can raise the FiO2 up to about 40%. By using these other oxygen delivery devices listed here, you can deliver more liters per minute of pure oxygen, and therefore the FiO2 can get higher, up to 100%, if you use a high-flow nasal cannula. And then finally, when you place a patient on non-invasive ventilation or mechanical ventilation, all the air that they are breathing is coming from the ventilator, and therefore you have complete control over the FiO2. The patient is not breathing any room air, and therefore you can get the FiO2 up to 100% or set it at whatever value you wish. So now let's talk about mechanical ventilation. Mechanical ventilation is ventilation via a machine that delivers oxygen and air into the lungs via an endotracheal tube, which means a tube that is inserted into the trachea. The ventilator machine forces air into the lungs, and this improves ventilation. It can improve oxygenation of blood and improve carbon dioxide removal. For any patient on a mechanical ventilator, there are a couple of variables that you can set. The first one is the inspired oxygen content, otherwise known as the FiO2. Room air has an FiO2 of about 21%, so for a patient on a mechanical ventilator, the level is usually set higher. It could be anywhere from 30% to 100%. You can also set a very important pressure called the PEEP, which we'll talk about in a minute. And then finally, you need to choose a ventilator mode. There are three modes: assist control, otherwise known as volume control, pressure control, and pressure support. And we'll talk about all of these in the next few slides. So let's talk about PEEP. PEEP is positive end expiratory pressure. And the idea behind PEEP is that alveolar collapse occurs in many lung diseases. And when the alveoli collapse, this impairs gas exchange. The point at which the alveoli often collapse is at end expiration, because this is when there is the lowest pressure in the respiratory system. Now, normally at the end of expiration, the pressure in the alveoli is zero. What the PEEP does is it raises that end expiratory pressure so that instead of 0, it could be 5 or 10, and this is going to limit the collapse of the alveoli. So let's imagine we have an alveolus right here, and if we're breathing room air, the atmospheric pressure outside the respiratory system is 0. When we exhale, the pressure inside the respiratory system, meaning inside the alveoli, becomes slightly positive at about +5 or so. When this becomes positive, we now have a gradient from +5 to 0, and therefore air flows out of the lungs, and that's what happens when we exhale. Eventually, this pressure of +5 starts to fall as air exits the lungs, and eventually it comes down to 0. And at 0, there's no longer any gradient for flow, so no more air flows. So this pressure of 0 inside the alveoli is the normal situation at the end of exhalation. The problem is, in certain lung diseases, that pressure of 0 is so low that the alveoli will collapse, and that impairs gas exchange. So what happens with PEEP is we basically change the setup, so the pressure out here will not be 0 like it is in the atmosphere. Instead, it will be a higher value, let's say, for example, 5. So if we made this pressure 5, that's called having a PEEP of 5. Now what's going to happen inside the alveoli is, instead of going from 5 down to 0 during exhalation, we're going to go from 10 down to 5 during exhalation. And at the end of exhalation, the pressure inside the alveoli will be 5 instead of 0, and that makes it less likely that the alveoli will collapse. So hopefully now it makes sense to you why PEEP is called end expiratory pressure, because it's the pressure at the end of expiration, and it's going to help to keep those alveoli open. And the important thing to remember in terms of patient care is PEEP works just like FiO2. It improves oxygenation. So it's easy to understand that if we increase the FiO2 in a patient on a ventilator from, say, 30% to, let's say, 100%, that's going to improve oxygenation. Hopefully you can understand that. The same thing happens with PEEP. If we go from a PEEP of 0 to a PEEP of 10, then we are going to improve oxygenation. PEEP is another tool available to any patient on a ventilator to improve oxygenation, just like raising the FiO2. So back to this slide, for any patient on a ventilator, you can set the FiO2 and you can set the PEEP. Once you've done those two things, you need to choose the ventilator mode, and that's what we're going to talk about now, these three different ventilator modes. We'll start by talking about pressure support, which is the simplest and most basic form of ventilator support of breathing. Pressure support simply adds positive pressure when the patient is inspiring. In other words, it has positive inspiratory pressure. When the pressure is high during inspiration, that's going to force more air into the lungs, and this is going to help to ventilate the lungs. And this is especially important when patients have an endotracheal tube in. Breathing through an endotracheal tube is like breathing through a straw. It's very difficult and requires extra force, and that's obviously a bad thing for a patient with respiratory distress. So by adding positive inspiratory pressure, you force air past that endotracheal tube into the lungs, and this is helpful to the patient so that the patient doesn't have to work so hard. So let's go back to our drawing of an alveoli. If you're breathing room air, the atmospheric pressure is 0. And when no air is moving, the pressure is 0 inside the alveoli. But then what happens when you take in a breath of air is the chest wall manipulates the pressure in the alveoli, so instead of 0, it becomes negative at about -5 or so. This creates a gradient to draw air into the respiratory tree and into the alveoli. The problem here is that your chest wall has to work in order to create this negative pressure, and for patients with respiratory failure, that's a problem, and you don't want them to have to work so hard to draw in air. So the way that pressure support works is instead of the usual situation where the pressure outside the lungs is zero, the ventilator raises the pressure, forcing air into the lungs and creates a high pressure, something like 15 or so. Now you have a situation where the pressure outside the alveoli is 15, generated by the ventilator. The pressure inside the alveoli is zero, and now we're going to get air flowing into the lungs this way, and this pressure, which is zero, is going to rise until it becomes about 15. This is very effective for ventilation because you're using high pressure to drive air into the lungs. The problem here, and this is a problem with all modes of ventilation, is you're applying positive pressure to the walls of the alveoli that don't normally see a pressure that high, and this can potentially harm the lungs through a process known as barotrauma. But nevertheless, this is what we often do, is we add pressure support to the patient by increasing the pressure outside the alveoli and forcing air into the lungs. So for a patient being ventilated via pressure support mode, you need to set three variables, and those three variables are the PEEP, the oxygen content of inspired air, otherwise known as the FiO2, and the inspiratory pressure. And the idea here is that you're really setting two pressures, a pressure generated for inspiration, and that's the inspiratory pressure, and a pressure at expiration, and that's the PEEP. Remember that when we've got this alveolus full of air, we're going to generate an inspiratory pressure, let's say it's 15, and that's going to drive air into the lungs. Then we're going to switch over to the PEEP, let's say it's 5, and that's going to allow air to come out of the lungs. We're going back and forth between these two pressures, 15 and 5, to allow airflow to go into and out of the lungs. The patient is going to determine the respiratory rate each time the patient begins to inhale. That's sensed by the machine, and that triggers a switch to the inspiratory pressure to drive air into the lungs. The patient is also going to determine the tidal volume, and tidal volume is very important. Remember, the more tidal volume, the more ventilation you have. And in this mode of ventilation, the tidal volume is not a set variable, it's determined by the patient. And this has important implications because patients who have stiff non-compliant lungs can have a very low tidal volume that they achieve for a given amount of pressure support. So let's go back to our drawing of an alveolus here. We have a patient breathing pressure support at 15. What this is going to do is drive air into the lungs until the pressure inside the alveoli and the respiratory tree becomes equal to 15. Well, depending on the compliance of the lungs, the volume it takes to get up to 15 inside the respiratory system may be different. In one patient, it may take 200 cc's of air to get up to a pressure of 15. In another patient, it may take 500 cc's of air to get up to a pressure of 15. The tidal volume varies based on the compliance of the lungs. Stiff, non-compliant lungs can only take a little bit of volume, like a few hundred cc's, and their pressure begins to rise. Lungs that are very compliant can take a lot of air before the pressure rises, so they might get a higher tidal volume like 500. It all depends and all varies with the compliance of the lungs. So the way this works is the machine will deliver air at that inspiratory pressure that you set until flow decreases. Usually it can detect when the flow has dropped by about 25% from the peak value. When this occurs, the pressure support is removed, it switches over to the PEEP, and that leads to exhalation. So once again, back to our alveoli, we apply a pressure of 15. Air begins to flow into the lungs. The pressure in the lungs starts to rise. It gets up to maybe 10, and then it gets up to 11, and then it gets up to 12. And at some point, the flow of air starts to decrease. And when this happens, the ventilator removes this and switches over to the PEEP. Let's say, for example, the PEEP is 5, and now airflow is going to reverse and come back out. And that's the way pressure support works. Very, very important point about the pressure support mode. The patient must be spontaneously breathing. The patient is determining the respiratory rate. So if you have a patient who has had a massive stroke and their respiratory muscles are not contracting, that patient can't be placed on pressure support because they will never trigger a breath. This is only a mode used for patients who are spontaneously breathing. The most common time you will see pressure support used is in patients who are being prepared for extubation. In other words, they're approaching the point when they can be taken off the ventilator. For those patients, you can set the pressure support and monitor them for a few hours to make sure their breathing status is good, and then you can reduce the pressure support and extubate the patient. If you understand everything I just said about pressure support, it's very easy to understand the second mode of ventilation, and that's called pressure control. This mode of ventilation applies a positive pressure at inspiration, just like we talked about in pressure support. The main difference between pressure control and pressure support is that in pressure control, a minimum respiratory rate is set. In other words, if the patient does not take a breath for a set period of time, say 2 seconds or 3 seconds, then the machine will automatically trigger a breath, and therefore you can use this mode in patients who are not spontaneously breathing. So the settings are very similar to pressure support. You set the PEEP, you set the oxygen content of inspired air, you set the inspiratory pressure, but there's one additional setting from pressure support, and that's the minimum respiratory rate. Once again, the tidal volume will vary based on the patient's compliance of their lungs. Stiff non-compliant lungs will have a low tidal volume. So typical settings you'll hear in the ICU for a patient on pressure control might be 15/5, at a rate of 12. What they're trying to tell you is that the inspiratory pressure is 15, PEEP is 5, and the respiratory rate is set at 12. Our final ventilatory mode is very different from pressure support and pressure control, and that's called volume control. The idea here is that the ventilator will fill the lungs until a set tidal volume is reached. So in pressure support and pressure control, we were setting the pressures, and we got whatever tidal volume we got. In volume control, we're setting the tidal volume, and that tidal volume is guaranteed using whatever pressures are necessary. This is often the initial setting used when patients are intubated. Patients who have just been intubated are usually critically ill, and so by using volume control, you guarantee that that patient will get a certain tidal volume of air. So let's go back to our drawing of an alveolus here. What's going to happen in volume control is the ventilator is going to raise the inspiratory pressure to some value, let's say it's 15. And this is going to force air into the lungs, and the machine is going to monitor that airflow. If it reaches the set tidal volume, let's say it's 500 cc's, then it's going to remove this pressure and switch to the PEEP and let air begin to flow back out. However, if it's unable to reach this tidal volume at a pressure of 15, it will raise it even higher, make it maybe 20, and then higher even to 25. It's going to keep raising the inspiratory pressure until it's able to get that tidal volume you have set into the lungs. So what's happening here is we're guaranteeing a certain tidal volume, say for example 500 cc's. The pressure required at inspiration to achieve that tidal volume is going to be varied by the machine until it gets us the number that we want. In volume control, you always set a minimum respiratory rate, so the patient can breathe at their own respiratory rate, but if it falls below the set rate, the machine will trigger a breath and make sure a minimum respiratory rate is met. So the settings in volume control are first the tidal volume that you want, then you set the PEEP just like you do in any ventilatory mode, you set the oxygen content of inspired air, and you set the minimum respiratory rate for the patient. As I've just said, the airway pressures are going to vary, and patients who have stiff non-compliant lungs are going to have very high airway pressures required in order to meet that set tidal volume. There are two modes in which you can set the ventilator for a patient on volume control, so let's talk about that now. The first concept you need to understand is that anytime you set a minimum respiratory rate, there are two ways the patient can get a breath from the ventilator. A spontaneous breath is a patient-triggered breath. So if a patient is breathing at a rate of 20 and the minimum rate is set at 10, then all those breaths are going to be initiated by the patient because that patient is over-breathing the vent, breathing at a rate higher than the set minimum. The other way a patient can get a breath is called a triggered breath. So if the patient does not take a breath of air for a couple of seconds, based on the minimum respiratory rate you have set, the machine will initiate inspiration. So this means that there are two types of breaths a patient can get from a ventilator when you've set a minimum respiratory rate, either a spontaneous breath triggered by the patient or a machine-triggered breath triggered by the ventilator machine. So if you understand that, then it's easy to understand the two modes of volume control. One is called assist control ventilation, the other is called synchronized intermittent mandatory ventilation, or SIMV. In assist control ventilation, all the breaths have the same volume of air, that set tidal volume. If you say the tidal volume is going to be 500, then every single breath in assist control, whether it's triggered by the patient or the machine, is going to have 500 cc's of air. In SIMV mode, if the patient triggers a breath, the patient is allowed to set their own volume based on various parameters. So in other words, the machine-triggered breaths will give a guaranteed tidal volume of, say, 500 cc's of air that you set. But if the patient spontaneously breathes, then the patient is allowed to set their own tidal volume. The theoretical advantage of the SIMV mode is that the patient-triggered breaths can be of a lower volume and sometimes a lower pressure in the lungs, so it may protect the lungs from barotrauma that they could be exposed to if every single breath is taken at the set tidal volume. So here's a summary of the three modes of mechanical ventilation. Let's go through them one at a time. First of all, you can always set the FiO2 and the PEEP for any mode of mechanical ventilation. In pressure support mode, the patient determines the respiratory rate. There is no set respiratory rate. You set the inspiratory pressure for the patient. And so example settings might be 15/5, meaning inspiratory pressure of 15, PEEP of 5, and an FiO2 of 50%. In pressure control mode, this is similar to pressure support mode, but you set a minimum respiratory rate. You also set the inspiratory pressure. So an example of settings you might report on rounds for pressure control would be 15/5 at a rate of 12 with an FiO2 of 50%. And then finally, volume control is that mode that we like to use right after we intubate patients. You set the respiratory rate, you set the tidal volume, and the pressures are determined by the patient. So example settings that you might report on rounds for volume control are a tidal volume of 500, respiratory rate of 12, PEEP of 5, and an FiO2 of 50%. Let's talk about some of the indications for mechanical ventilation. The major ones are hypoxemia and hypoventilation, and by hypoventilation I mean an elevated CO2 level. This could be ongoing or it could be anticipated. If a patient is very sick and you anticipate respiratory failure, sometimes mechanical ventilation will be started ahead of time so that respiratory failure never occurs. The second indication is protection of the airway. So you have protective reflexes in your airway that prevent aspiration, and when patients have catastrophic neurologic events, they lose their airway tone and they can develop aspiration. So in these situations, an endotracheal tube is always inserted and mechanical ventilation is started until the patient recovers enough to protect their airway. So these are usually patients with neurologic impairment. Either they have a coma or they've had a stroke or a brain bleed or something along those lines. Let's talk about some basic principles of how to manage patients on mechanical ventilation. First of all, after the patient's been intubated, one of the first things you want to do is check that the breath sounds are equal in both sides of the lungs. If the breath sounds are not, it could mean that the endotracheal tube is pushed down into one side of the lungs and the other side is not being ventilated. Beyond checking for breath sounds, you want to check the chest tube placement via chest x-ray. Normally the chest tube should end about 2 to 5 centimeters above the carina. If you look at this chest x-ray on the screen here, you can see the faint outline of the trachea, which bifurcates into the left and right mainstem bronchi. That bifurcation site is the carina, and this is the endotracheal tube right here. And you can see it's at a point here, which is a couple centimeters above the carina. That's the normal location of where the endotracheal tube should be. If it's all the way down here, you need to pull it back, and if it's way up here, you need to advance it further. And then the way you want to monitor patients on mechanical ventilation is by drawing arterial blood gases. And because these patients often need multiple arterial blood gases, they often have an arterial line placed where you can draw an ABG off that line anytime you want. Once you draw an ABG, you make ventilator changes based on the results. If the patient is hypoxemic, you can either increase the FiO2 or increase the PEEP. Usually the goal PaO2 for patients on the ventilator is a PaO2 greater than 60. So if the patient had a value lower than this, you can raise the FiO2. You can also raise the PEEP. Remember what I told you before, raising the PEEP is the same thing as adding more FiO2. If the patient has hypercapnia, then you can increase the respiratory rate or the tidal volume. So a normal PaCO2 is about 40, and that's what you want the PaCO2 to be for patients on the ventilator. You don't want them to be acidemic or alkalotic because that can interfere with their recovery and with the function of medications. If the PaCO2 is elevated and the patient is in a ventilator mode where you set the respiratory rate, then you can increase the respiratory rate. Also, if they're in the assist control mode, you can increase the tidal volume. Either of these two maneuvers will increase the minute ventilation, and that will blow off more CO2. Let's talk about oxygen toxicity. So high concentrations of FiO2, meaning high concentrations of inspired oxygen, can lead to lung damage. Now, when we initially ventilate patients, we usually start them off at an FiO2 of 100%. But once you get the patient stabilized, you want to try to lower the FiO2 below 60, which is the level that's usually considered safe. So what you do is you slowly turn down the FiO2, checking arterial blood gases to make sure the patient remains well oxygenated. And remember what I said before, you can always increase the PEEP to increase oxygenation. So in patients who are difficult to oxygenate, sometimes you lower the FiO2 but raise the PEEP in order to get that patient to be well oxygenated and to keep the FiO2 down below the 60% level. Let's talk about weaning patients off the ventilator. First of all, you can't wean any patient off the ventilator unless they are alert and arousable. Patients who are not alert and arousable need continued ventilation. And then what you usually do when you're preparing to extubate a patient is what's known as a spontaneous breathing trial. In this trial, you let the patient spontaneously breathe through the endotracheal tube, usually for 30 minutes, and you monitor their respiratory rate and oxygenation level. You usually set the ventilator to minimal support. This is often a pressure support mode. I told you before, pressure support modes are commonly values like 15/5, which means a pressure support at inspiration of 15 and a PEEP of 5. For a spontaneous breathing trial, you will often set the levels as low as 5/5. At this point, the patient is basically breathing on their own with no support, and if the patient's able to maintain that for 30 minutes, then they can be safely extubated. When you have a patient on volume control ventilation, remember that you're forcing air into the lungs and allowing the pressure in the lungs to climb as high as it needs to climb in order to get that volume of air delivered. When you do this, you will sometimes have the ventilator alarm telling you that the pressure in the patient's lungs is getting dangerously high. And when that happens, the first step you need to take in order to figure out why the pressures are high is to do a ventilator technique called an inspiratory hold. This is a ventilator technique used in patients on volume control ventilation to evaluate high pressures. The way an inspiratory hold works is the tidal volume is delivered, but then the ventilator briefly does not allow the air to come out of the lungs. It stops airflow. And while this is happening, it measures the change in pressure. Let's look at this graph on the screen here, which is an example of the type of data you get from an inspiratory hold maneuver. At this point here, air begins moving into the lungs, and that obviously causes the pressure to rise. At this point here, the tidal volume has been delivered, so therefore the ventilator stops pushing air into the lungs. Normally, air would be allowed to leave the lungs at this point, but in an inspiratory hold, the ventilator briefly does not allow air to leave the lungs. When this is done, the pressure will settle out at a pressure called the plateau pressure, and the machine will record the plateau pressure for a brief period, and then it will allow air to exit the lungs. So there are a couple of important things you can glean from this graph. The first thing to know is that this right here is the PEEP. That's the end of expiration, and that's the pressure that you have set the machine at for PEEP. These other two pressures, the peak pressure and the plateau pressure, tell you different things. The peak pressure depends on the compliance of the lungs, but also the resistance to airflow, because air is moving into the lungs during this portion of the curve here. But the plateau pressure does not depend on airflow resistance at all, because airflow has been stopped, so that eliminates flow resistance. And therefore the plateau pressure is only influenced by the compliance of the lungs. It is not influenced at all by airflow resistance. So you can measure the peak pressure with an inspiratory hold, and you can measure the plateau pressure, and the plateau pressure depends only on the compliance of the lungs, the elastic pressure plus the PEEP, which is the pressure you start at. So here's a table showing you how you can interpret those pressures to figure out why a patient is alarming with high pressures during volume control mode. If the peak pressure is high and the plateau pressure is high, this tells you the lungs are stiff with low compliance. Because remember, the only thing that will make the plateau pressure high is poor lung compliance. And in many lung diseases, patients have poor lung compliance, especially things like ARDS, and you can see it in pulmonary edema and other causes of respiratory failure. If, however, the peak pressure is high but the plateau pressure is normal, this tells you that the problem is airway resistance. And the usual cause of airway resistance in a patient on a ventilator is mucus plugging. When mucus plugs up the bronchioles, it makes it very difficult to force air in, and that will raise the peak pressure, but it will have no effect on the plateau pressure because lung compliance hasn't changed. So the big picture here is that by doing an inspiratory hold, you can get this data like I've shown in this table, and that will tell you whether the problem is that the patient has stiff lungs from their lung disease, or whether the problem is mucus plugging and something related to airway resistance. Let's talk about some of the indications for mechanical ventilation. The most common indication is persistent hypoxemia. If a patient has hypoxemia and you use some of the oxygen delivery devices we talked about earlier in this video, but yet the patient continues to have a persistently low oxygen saturation, that patient usually needs mechanical ventilation. Another common indication is unresponsiveness. Patients who are unconscious cannot protect their airway. Their airway can close off or they can aspirate, so these patients usually need to be intubated and placed on a mechanical ventilator. And then finally, a super high yield indication for mechanical ventilation, one that will certainly come up in your board exams, is respiratory distress with normal or increased carbon dioxide level by ABG. When patients have any respiratory disorder, be it asthma, COPD, or pneumonia, or heart failure, they will develop an increased respiratory rate, and if they have a severe respiratory problem, they can even begin using their accessory muscles. These things are going to increase the ventilatory rate, and therefore the carbon dioxide level should get very low by ABG. If you do an ABG and the carbon dioxide level is not low, but instead it's normal, or maybe it's even increased, that is a very bad sign. That means that that patient's respiratory muscles are fatiguing, and it means that the patient is beginning to hypoventilate. So a normal PaCO2 is about 40. A patient who has a high respiratory rate should have a PaCO2 much lower than that, usually around 20 or 30. If a patient in respiratory distress has a PaCO2 that's 40 or higher, that is very bad. That patient is hypoventilating. Usually the next step is to intubate them and initiate mechanical ventilation. I'll finish with this slide on mucus plugging. Mucus plugging refers to a glob of mucus that rolls down the airway and obstructs one of the bronchi. This occurs in many lung diseases, and it's very common in patients on ventilators, and it causes airway collapse and limits ventilation. When an area of the lung is affected by a mucus plug, there will be decreased breath sounds in that area and dullness to percussion. On chest x-ray, the area of the lung with a mucus plug will be opacified, and if it's a large area, the trachea and mediastinum will deviate toward the affected side. Shown on this slide is a chest x-ray of a patient whose entire left lung is affected by a large mucus plug. You can see that the trachea is deviated this way towards the affected side, and basically there's just whiteout, which is what happens when there's mucus plugging. The treatment is to suction out the mucus plug, or in some cases bronchoscopy. In the ICU, there is suction usually available at the bedside, and nurses often suction the back of patients' throats to try and clear out any mucus and prevent mucus plugging. And that concludes our video on respiratory failure.